Now I would like to invite our first speaker, the renowned glaucoma specialist, not only in Bangladesh but also in international field, Professor Nazrul Islam sir. He will talk on Gonioscopy Made Easy.
Assalamu alaikum and good morning. Honorable panelists and my dear colleagues, my presentation is absolutely mostly for my students, for my residents. Gonioscopy is a technique that all ophthalmologists should learn, especially those who want to be glaucoma specialists, definitely. I don't have any financial disclosure. If you look here in this video, that it is a clinical gonioscopy, I am doing it. First of all, very important is the room light. You should dim it, then hold your gonioscope in such a way that it should be stable on the eye. And you can understand the light here in the above the pupil, not in the eye, in the above the pupil. And after putting the gonio lens, then you bring your light to the eye, to the angle. This is very important. Otherwise, if you put light to the eye first, the eye will be constricted, people will be constricted, and you will find a open angle. That will be misfinding. So the question comes, how you learn this. It is simply practice. It's not very difficult. So can I ask my students, how many of you are doing gonioscopy now? Please raise your hand. Any? My God, not many, not many. So I hope after that presentation will be inspired to do it. It's not very difficult. Only thing is practice. If you really want to do it, definitely you can do it. Nothing problem. So first of all, why should you learn gonioscopy? Number one, if you want to examine your eye, the eye is having angle closed or open. Is must to know. Every ophthalmologist should know. Not only glaucoma specialist, everybody. Before dilating, you should not make a acute glaucoma after dilating. So must do, especially the Van Herrick's method. If you find the corneal thickness is less than half, definitely you should go for gonioscopy. If you do not know gonioscopy, you refer the patient to someone who knows this. Because without this, if you do dilate, you will be in problem. So it's very important. And definitely, if you consider that patient is having diabetes, patient might have neovascularization, patient some pigments after the trauma, such a specific indication, we must do gonioscopy. And another important is a therapeutic. You know that now recently we are doing SLT, selective laser trabeculoplasty, laser, we are doing the angle surgery, minimally invasive glaucoma surgery, all dependent on the angle and by the direct gonioscope, surgical gonioscope. So very also important thing. So important is, you know that two kind of gonioscopy we have, direct and indirect. Direct means surgical gonioscope, mostly patient lying down during surgery we use it, and indirect for the clinical purposes. We know that refractive index of air is 1, but refractive index of cornea, tear is 1.5. So when there is some light reflected from the angle, it does not go out. It is totally internal reflected back because of the difference of the refractive index. But if you put a lens over here, the gonio lens, the refractive index is overcome. So in gonio lens is 1.5 and cornea is 1.4, so almost similar. So the light from the angle can go directly to the mirror and you can see. So it is the optical principle of gonioscopy. So first of all, few words about the surgical gonioscope. It is being very tremendously improved recent years because of the development of the MIGS surgery, minimally glaucoma surgery, the angle surgery. These are the Gonioscopy, Barkan and Son Jacob. These are the lenses that mostly used in the surgical field. But recently, Dr. Aik Ahmed and other surgeons, they have made improved version of the surgical gonioscope. Let me share one of my surgeries, the bang surgery, we call it bang, bent ab internal needle goniectomy. It is a mixed surgery, but very cheap. We can do it in Bangladesh. You can see here I am using the bent needle, 27G needle, and excising this trabecular meshwork. So this is one of the mix, or the very cheap mix. It is the bang surgery, very popular now throughout the world. It is first published by Dr. Shaibani from America. The brain came from America, but now being used in Bangladesh, in India, Nepal, and many places. It is very popular now because it does not cost anything. That is very important. So now coming to our regular gonioscopy, that is called indirect gonioscopy, and I will request our residents to see this, because this is the picture that you keep in your mind, that this is the angle. This is the angle, the termination of the displacement, the Solbes line, trabecular meshwork, anterior, posterior, SCLS spar, ciliary. These are the things we have to see. These are the portions to see. But if you look to the eye, it will be like this. This is the Solbes line, ATM, PTM, and SCLS spar. In the gonioscope indirect, we see opposite, but the orientation becomes same. That the right side will be right side, left side will be left side. Like if you see the 12 o'clock, you will see the 6 o'clock position of the angle, but on the right side is 5 o'clock, left side 7 to 7. So same orientation is there, but with the opposite angle. Now, what kind of lenses we use? Mainly two types. One is a scleral type, another is corneal type. The advantage of the scleral type is that it is very easy. The beginner surgeon, you can start your gonioscope practice with the scleral type by 1 mirror gonioscope, 2 mirror, 3 mirror gonioscope, like that. We have very good quality gonioscope like Latina, Magna View. Of course, you can do that. It is very easy. Problem is you cannot do indentation with this. This is very important. I will come later. It's very important. These are beautiful lenses that can be learned by the beginner also. If you look here, I'm using the scleral type of gonio lens to do my selective laser trabeculoplasty. You will see, I can see the angle so nicely. Sorry. Even a person, a doctor who do not know gonioscopy, even he will be able to say what is the structure here. You can see very nicely the trabecular meshwork. I'm putting the laser over the trabecular meshwork. So doing the gonioscopy, learning gonioscopy, it is very easy also to do laser in the angle. It's very important. Without knowing this, you cannot do that. On the other hand, as I am doing many SLT, you will learn more gonioscopy. It's very important alternatively. So it's very easy to see it. But if you become oriented, then your practice should be by 4-mirror gonioscope. It is mostly Zeiss, Posner, or Sussman. I prefer the Posner one. And because why? Most important part is the indentation gonioscopy, which is very much important. Why? Sometimes if you put the gonio lens, you will see its angle is not open. But if you indent angle, you can see the open. So very important to see indentation. And for this, you need these 4-mirror gonio lenses, maybe Posner, maybe Zeiss, or maybe Sussman. And of course, you can see the 4 quadrant, similar in same practice. I'll request with a big checklist, but everything is important in this 12 part for my dear colleagues, for my residents, that you must do this before doing gonioscopy or during gonioscopy. Room should be dim lighted. Patient must be well anesthetized, giving 2 to 3 times anesthesia, topical anesthesia, and fix your hand. Like this, every point is very important to start and to do gonioscopy here. I think those who have done gonioscopy, it is a very common thing. And this 4 structure we must learn. What is the 4 structures? If you come from behind, is the SCLS spar. This is the trabecular meshwork, posterior pigmented trabecular meshwork. This one is the anterior non-pigmented trabecular meshwork. And this is the Solbes line. So this 4 structure we will see, try to see. Solbes line, ATM, PTM, SCLS spar. It's very important. If you cannot see the Solbes line, then you can take the help of corneal OS. It's not very easy to see, though in the book it is written, but it's not very easy. But with practice, definitely you can see 2 reflection, one coming from the anterior part of the cornea and from the posterior part of the cornea, making in the Solbes line. The corneal OS can give you the area of Solbes line. I think I'll request you to see this very carefully, what I'm doing. I'm pressing the gonioscope very lightly over the eye. And what I'll see, you'll see here, I cannot see all the structure. Without indentation, if you look here, I cannot see all the structure here. Not all 4 structure. But the same eye, when I indent with the gonioscope, you will see all the structure, 4 structure is visible. So what is this? This is a appositional angle closure. And many times, all our cataract surgeon here, you know that in the early cataract, the pressure comes with 25, 30, patient complaining of rainbow halos, headache, eye ache, and if you see gonioscopy, you will see there is a appositional angle closure. If the patient is having little cataract, I think the cataracts will be very happy to do the cataract extraction because that is the right treatment. But if the patient cannot want to do, definitely you can do the laser PI in these cases. So indentation is very important part of your gonioscopy. So let us see some of the examples. This is the very nice open angle. All the structure is visible here. It is a close angle, not visible. Here, a spot is not clearly visible, but if you look here, it is possible to be see. So sometimes you will not see all clear, but you have to look for to see the structures. Here again, you can see all the structure, and you can see some pigmentation over the Solbes line. We call it Sampoulosis line. So these are the things you will have to practice, see many, many hundreds of cases, definitely will learn it. Now coming to the grading, there are different way of grading, but most important is Schaeffer's grading. Sometimes we also use the space grading. For remembering, I will say that if you can see all the four structures, the grade is 40 degree, grade 4. If you can see the anterior 3 structure, grade 3, 30 degree. If you can see anterior 2 structures, that is Solbes line and ATM, it is grade 2, 20 degree. If you see only Solbes line, grade 1, 10 degree. If you cannot see any structure, grade 0, 0 degree. So this is a very simple way to memorize the grading and of the angle. Space is not very important for us, but still sometimes to see the plateau iris, you need to know it, that the iris insertion is anterior to Solbes line or behind the Solbes line, it is deep or extremely deep. So this way ABCD is a kind of classification given by Spieth. Now, it is very important to write the documentation, what kind of angle it is, you must have to write it. That was for the research purpose mainly used, but this is clinically we use it. This is the inner part, this is the Solbes, here it is the slash part, outer shows the Solbes line, and inside you can see the trabecular meshwork. Simply you can write like this 2 line, the angle is 0 in all quadrants, or it is PTM, ATM or SS, just like this. Whatever you find in each quadrant, you must write here like this. So it's very easy, you can do it. Next, I don't have any financial interest. NITEC has brought a very good instrument in it, NSGS1. By this instrument, you can do your gonioscopy by 1 minute. You can have a very good video, still photography. So it is those who have the capacity, definitely. I'll request here my chairman, Mohammad Chaudhary, please purchase a gonioscopy machine for us. It gives a very good 1 minute examination, and you can find the whole thing, and you can have a good documentation. Now, I think because of time, I will not go first. I'll go first. Iris process, sometimes you see it is physiological, but it should not be misnomer with the pass prevention, which is very broad-based. And this way, with the practice, you will learn it. You can see pigmentation here, 1, 4 plus, 3 plus, 2 plus, 1 plus. So this is the pigmentary glaucoma you will find like this. Pseudo exfoliation, you can see similar material and Sampoulosis line in this case. This is very nice Sampoulosis line. When there is pigmentation of the Solbes line, we call it Sampoulosis line. We know that after trauma, we can find glaucoma, secondary glaucoma. Why? The angle is traumatized. There is recession of the angle structure towards the ciliary body. So you can see angle recession. In the diabetic patient, definitely you can see, you can see the neovascularization. Sometimes you can see in the angle. This is very important slide, plateau iris. Sometimes you can see there is some curvature change in the iris by this. You can see the convex, concave, convex, double hump pattern. Why? Because of the lens, one hump, and because of the anterior position of the ciliary process, another hump. So this is the plateau iris, and you can see the double hump pattern you can find in the gonioscope. This is I make it for my students that if you can say the diagnosis, anybody can say, it is pigmentary glaucoma, pigmentary special syndrome. This is pseudo exfoliation glaucoma. This is, you can see, iridodialysis. So this is very blood in the anterior chamber, having blood in the angle, post-chromatic. This is the, I mentioned, the Sampoulosis line in pigmentary glaucoma. This is, anybody can say here? Niyaz bhai? Silicone in the oil in the angle. And this is the MIGS, the eye stent put in the trabecular meshwork. This is a recent surgery. So this is I stand. So I think this is a very short presentation on gonioscopy. If you are really interested to see more details, I have a presentation in the YouTube, in my YouTube channel, you can see that. Thank you very much.
Thank you, sir, for a very wonderful presentation as always.